And that leads into our hemolytic anemias. Question. A healthy 12-year-old presents with a history of intermittent scleral icterus and seems tired. He had rhinorrhea and cough 3 weeks ago, which have resolved. He has mild splenomegaly. Which of the following blood test results are consistent with the diagnosis? A. Elevated haptoglobin. B. Elevated direct bilirubin. C. Elevated retic count. D. Decreased ferritin level. E. Decreased lactate dehydrogenase. The correct answer is elevated reticulocyte count. The child in this vignette has scleral icterus and splenomegaly, which are signs of hemolysis. Reticulocytes are immature red cells that exit the marrow prematurely to compensate for the hemolysis. Answer A, elevated haptoglobin, is incorrect, as it is seen in inflammation, while a decreased haptoglobin is seen in hemolysis. Answer B is incorrect. Elevated direct bilirubin is seen in liver disease, whereas an elevated indirect bilirubin is seen in hemolysis. Answer D is incorrect. Decreased ferritin level is suggestive of iron deficiency, which is inconsistent with this story. And the incorrect answer, E, decreased lactate dehydrogenase, is the opposite of hemolysis, where there is an elevated lactate dehydrogenase level in hemolysis. So first, we like to think of the causes of hemolytic anemias. And I like to think of extrinsic causes and intrinsic causes. An extrinsic cause may be due to immune-mediated hemolytic anemias, such as red blood cell antigen incompatibilities, or something called autoimmune hemolytic anemia. Or it also may be due to red cell destruction, mechanical heart valves, hemolytic uremia syndrome, or drugs. Intrinsic defects of the red blood cell include inherited red cell membrane disorders, such as hereditary spherocytosis or leptocytosis, inherited red cell enzyme disorders, such as glucose 6-phosphate dehydrogenase deficiency, pyruvate kinase deficiency, and others, and inherited red cell hemoglobin disorders, such as sickle cell disease, thalassemia majors, and others. Let's talk about extrinsic causes due to immune-mediated phenomena. One is called autoimmune hemolytic anemias. This may be a primary cause, meaning the person has this develop in their body for whatever reason. Sometimes we cannot figure it out, where there are warm antibodies, and this presents when you look at the direct antiglobulin test with positive immunoglobulin G antibodies to the Rh antigen on the red blood cell. Cold antibodies, on the other hand, produce IgM antibodies to the I antigen on the red blood cell. Secondary causes of warm antibodies include autoimmune disease, immunodeficiencies, and malignancies, whereas in cold antibodies, often seen in children after mycoplasma infection, Epstein-Barr virus, or rarely seen in lymphoproliferative diseases. The diagnosis is made by noticing anemia or low hemoglobin, an elevated retic count with spherocytes on the smear, an elevated indirect bilirubin, a low haptoglobin, and a positive direct antiglobulin test. Please remember that direct antiglobulin test used to be called COOMS, C-O-O-M-B-S. For cold antibodies, you might also find a positive cold agglutinin test and positive mycoplasma titers. Please consider talking to your blood bank or hematologist about obtaining these tests. Treatment for warm antibodies are usually corticosteroids, and it's a high dose with a slow taper over several weeks to even a month or two. In the acute setting, transfusions are often necessary. Intravenous gamma globulin can be considered, and splenectomy is required if it's a chronic condition, but it's not one of the main treatments. In cold antibodies or cold autoimmune hemolytic anemias, corticosteroids are contraindicated. They are not effective. The main thing is to keep the person warm, Plasmapheresis might be necessary to remove the antibodies from the bloodstream to stabilize the patient. And in the chronic setting, there are some immunosuppressive agents that can be used. Those are more rare in children. Intrinsic disorder of the red cells include the membrane disorders. And this is where you are born with a genetic mutation that makes the red cell membrane skeleton fragile. And there are multiple mutations resulting in varying severity of chronic hemolysis. The different labels of them include hereditary spherocytosis, elliptocytosis, xerocytosis, stomatocytosis, poikilocytosis, and others, believe it or not. In the old days, we used to only call it spherocytosis or elliptocytosis, when we were wondering why there was such variability in their presentation. So we know more about the membrane disorders now. In general, though, a person who presents with that will have a low hemoglobin, obviously signs of hemolysis such as an indirect bilirubin elevation, lactate dehydrogenase elevated, uric acid elevation, elevated retic count, and a low haptoglobin level. The smear will be abnormal, showing different shapes of the red blood cells. You would need to get an incubated osmotic fragility test, and that might be abnormally increased or decreased. Genetic testing has come a long way and is very important. Please discuss with a geneticist or hematologist before getting the panel. But you will also notice on children with this type of hemolysis that their DAT or direct antiglobulin test is negative. This is not immune mediated. This is something they've inherited and they'll have their whole lifetime. I should also mention of note that those with mild membrane disorder will sometimes not be anemic. They will have a high retic count and will have some scleral icterus, which will prompt the pediatrician to notice that there is a slightly elevated bilirubin. So we often recommend getting a retic count when you ever see a slightly elevated bilirubin to see if there's an underlying red cell membrane disorder, and please refer to the hematologist. Treatment for these conditions are typically supportive. Most are mild, but in extreme situations, if triggered by an infection, they may need a transfusion. Folic acid supplement may be used, especially if they have limited diets or they're hemolyzing rapidly. And splenectomy is only used for severe diseases. And please consult the surgeon and hematologist before suggesting splenectomy. One of the most common enzyme deficiencies in the world is called glucose 6-phosphate dehydrogenase deficiency. I'm not going to talk about the other enzyme deficiency, which are more rare, because they have similar presentations and treatments. The G6PD deficiency has variable severity. It's found in people of African, Mediterranean, or Asian descent. It's X-linked inheritance. So often people think, oh, it's only found in males. That is false. Women also inherit this genetic mutation on their X chromosome. However, some women do not express the X that has this mutation on it, whereas other women do express the X that has this mutation on it. So it is important to screen females for this if they've had hemolysis. Features include episodic hemolysis, typically triggered by stressors such as drugs, in children sulfonamides and antimalarials, often mothballs or naphthalene. Naphthalene can also be found in cleaning products. Fava beans are large flat green beans that kind of look like large lima beans that are found in some diets. They're a great source of iron and fiber, but they will trigger hemolysis. Infections may trigger hemolysis in those with G6PD deficiency. And in this condition, this more severe G6PD deficiency can cause neonatal jaundice in the first 24 hours of life, with severe kernicterus requiring exchange transfusion. So G6PD deficiency should be considered in those infants with severe kernicterus, or in any person with jaundice, high red tick count, and anemia. Now, the diagnosis is made with a G6PD enzyme assay. However, this value is falsely elevated in situations of hemolysis, where there's reticulocytosis, and when you're a newborn. G6PD is found in reticulocytes, and if you're deficient in this, as that reticulocyte matures, the mature red blood cell doesn't have it on it. And in newborns, all newborns have great glucose 6-phosphate dehydrogenase levels. So it's difficult to diagnose. You might have to wait till after all of the hemolysis and months after a transfusion. As you know, people who donate blood do not have G6PD deficiency, and you must wait for the transfused product to be eliminated from the body before you can obtain a G6PD level. So if you're going to get a G6PD level, make sure the person is hemodynamically stable, the CBC and retic count is seemingly normal, and then you could get your G6PD level. If any questions, please contact your hematologist. The treatment for this condition is you want to avoid all the offending agents, so we often give the family a list of medications and chemicals to avoid in their lifetimes, and we also put it in their chart so that anesthesiologists are aware and pediatricians are aware, and everybody's aware of what medications to avoid. In severe hemolysis, transfusion is often necessary.